We are Q100.7 FM, and when you hear that pulse, you hear that sound, we know it is time for the Pulsed QEH radio show. We've got Shane Seeley in with us, and of course he does not attend alone, so we're going to go straight over to Shane so that he can introduce his guests. Of course, the Pulse radio show brought to you with the kind of compliments of Medic, and I want to get that right, brought to you with the kind compliments of MedSafe Supplies. For all your medical supply needs, visit MedSafe Medical Supplies Limited. They offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and much more. Conveniently located on Gemmitts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, they deliver free to the Queen Elizabeth Hospital. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call them at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
A pleasant good morning to you. Welcome to the Pulse Radio Show. I'm Shane Seeley, Communications Specialist with the Queen Elizabeth Hospital. I'll be your host this afternoon. This morning. It's not afternoon yet. We can't rush the time. It normally goes pretty fast.
Yes, it
in
does.
This hour on radio. And
I'm Rhea Corbin-Hart, Manager for Patient Relations at the QEH, and I'll be your co-host this morning.
As always, my co-pilot.
Yes. This morning we have a guest here in the studio. We have Miss Sandra Beckles-Hackett, who is the manager for the QEH Clinical Risk Management Unit. And she's here this morning to talk about this unit, what it does, what services it offers to you, the public, and our patients at the Queen Elizabeth Hospital, and to let us know how we can contact the Clinical Risk Management Unit. Sandra, nice to have you here. Good morning and welcome.
Good morning, and thank you for welcoming me. I'm very thankful for the Pulse team and the QEH, as well as the CBC team, for welcoming the Clinical Risk Management Unit here to your radio station.
Yes.
Thank you.
Yeah, before we get anything else, I got to thank Sandra in a big way for praying for us.
Yes.
Before we started today's broadcast. That is so important. You know, it's always good to give thanks. And we're giving thanks that we are able to share the information with the public every week at this time, 11 a.m. till 12 p.m. And a big thanks to MedSafe as well for supporting us as we embark on this journey where we connect with you. It's all about making sure that we, as the QEH, keep connected with our patients, their families, our visitors as well. Speaking about connection, and later on we will connect with Dr. Margaret O'Shea as we talk about transplants as well. That will be our highlight today. But Rhea, we're talking about clinical risk first. It's all about.
Yes, we are.
Sandra has a busy job, dealing with a lot.
Yes, so Sandra, tell us about the Clinical Risk Management Unit.
Okay, let's start with a little bit of history of the Clinical Risk Management Unit. We came about in July of 2006. Before that, the foundation was set by the Risk Management Committee of the board. Remember, back in 2015, we would have turned from general government over to a board of government to cover us, our operations. So one of the things that was asked for was our cover for medical negligence, and one of the things that was requested was to have a department within the hospital that was managing or a repository for the risks that were reported, and to have the feedback from the general public, from our customers. So one of the things that we started with was the Clinical Risk Management Unit with a very small team of me. And then we have now moved on to a small team of 5 of us. We have now a clinical risk officer, we have 2 clerks, and we have an administrative assistant. A big feat for a small team, but we have very good the dedicated workers in part of the department, and they press in to actually give their best as we look at the risks affecting the institution.
The name of the department is quite a mouthful. Clinical Risk Management Unit, CRMU. Explain to the public why this is so important for the Queen Elizabeth Hospital to have a department like this.
Yes, it is important because remember our major business is clinical care, and one of the major business of the clinical risk management unit, and by extension the hospital, is patient safety. And clinical risk management is one of those tools used to measure and monitor how well we are doing as it relates to patient safety. So it's a long word, but you're using the clinical because remember the insurance and the finance industry, we have risk management. So that we are specific as it relates to our healthcare management, we've gone on with the clinical risk management unit.
Understood. So you mentioned that you want to monitor, but I also get the impression that it is all about receiving the feedback from the persons who are actually involved in getting clinical care from the hospital. Can you tell us a bit more about that?
Okay. That part of the monitoring is getting the information. You can't fix something unless you know that something exists. Or in some cases, what we need to do is to be proactive and look to see what is happening out there. What are the risks affecting other hospitals similar to us, and what we can learn from them. But primarily here, what we have done, apart from the internal customers letting us know what is happening in their areas, we welcome feedback from our visitors, from our patients, from their relatives, and we have welcomed that so much that we've opened a whole lot of avenues for that. So, and apart from that, we recently had our Datix incident management system upgraded, and it is no longer a complaints module. It is called now a feedback module, because we are now capturing both the complaints as well as the compliments. So what we have is, like persons looking in on us and say, because we might feel good that we are doing certain things very well in certain areas, but when persons look in on us, they might be picking up things that we need to take stock of. So we welcome those compliments and those complaints and even suggestions. Some persons give very good suggestions as to how we can improve our services.
So they're bringing their fresh eyes and their ideas to be able to assist us to assist the public.
Yes.
So these avenues, can you tell us a bit more about the avenues? What are the different ways that persons can give us this feedback to the clinical risk management unit?
Okay. For those persons that are computer savvy, we have QEH Connect, which is our website for the hospital. And on QEH Connect, you're going to see there is a field there for clinical risk management unit. And that takes you to how to make complaints, as well as the complaints form is there. The newly updated form by the clinical risk officer is right there, that you can click on it, fill that out, and send that in to us. The other avenues we have, you can call into the department and alert us that this is something that is happening, and we will guide you as to how best you can report to us. We also have, you can walk into the department. We have the forms there already where you can fill the form out, and we give you the acknowledgement letter the same time, let you know this is your official document that we have acknowledged receipt of your concern.
So like a receipt?
Yes. We also have, you can email in your concern as a regular email, or as I told you before, you can email in the complaints form. Yes.
So can you share with us the email address and the telephone extensions that persons can reach the CRMU or Clinical Risk Management Unit?
Yes. The email address is crmu@qeh.gov.bb.
Okay.
I say it again, crmu@qeh.gov.bb. The telephone numbers into the department are the switchboard, which is 436-6450, and you have extension 5248, 5249, 5247, 6818, 5234, and 6334.
And I want you to know that Mrs. Beckles-Hackett has called all of those numbers off of the top of her head, but we want to make sure that you get them. So we will repeat them as we go through the program, and also we want your feedback here live on the Pulse Radio Show. You can always call us at 434-1007. That's 434-1007 and 434-1070. And the 434-1007 is also a WhatsApp number that you can call, because we want to hear from you. Just as Mrs. Beckles-Hackett, she wants to hear from you in terms of your concerns, your compliments, because it's all about using those to enhance the services that we provide at the Queen Elizabeth Hospital on a daily basis. Mrs. Beckles-Hackett, maybe you can give us a very practical situation, how we have done that, use some of the complaints that we have been receiving to make things right for our patients and visitors as they come through the hospital.
Okay, that's great. I can go from the very simple to the more complex. For instance, somebody would come by and they said, years ago, there was water on the corridor and there's a potential for somebody to slip. Remember the suggestions?
Yes.
And what we did, we commandeered and we got the wet floor signs, and these are strategically placed along the corridors that anyone, if they see water, so that, because remember, the institution, we're going to have persons that are not going to be very able-bodied moving around, or not be able to see well. And what they have, you can have the wet floor sign to put it in the space so that you alert persons before somebody from the housekeeping department can come and mop the water up. From simple as that to we would have been having issues, let's say, with persons say, they weren't comfortable with how the consent process was when they make a complaint. And what was done a couple years ago, the whole complaints process was looked at, and a new policy was put in place for consent, and also some new forms for consent. And what those forms did, it pushed personnel to actually be more in depth in the information that they gave to the patients and relatives in preparation for surgery. And when we were comfortable and the documentation was there, that we were comfortable, yes, this person is now signing with the knowledge of what they're going to be going under. So those are a few of the things practical that we have come through so far.
Yeah, very practical examples there. So thank you so much for that. So you mentioned you like to get the feedback, you monitor, you take suggestions, and then you put a solution in place. Can you give us a timeline of how persons who come to the clinical risk management unit or email or call or go to the website, when they put forward their complaint or suggestion or even compliment, what kind of timeline, what are the next steps, what should they expect next?
Okay, so we have it's so strict. We have a policy that controls how we manage the complaints. This policy is the complaints policy, and it specifically states that we need to respond to the complainant with an acknowledgement letter within 2 working days.
48 hours.
Within 2 working days. And then when we have done our investigation, so we send the correspondence that we send them at that point in time or hand to them at that point in time actually outlines this. We offer a 40 working day. This is one of the things that we have improved on. Before, we used to use 20 working days for a final response. And with the dynamics of the health institution, and when, for instance, if we are dealing with a complaint where we're dealing with different levels of staff, it was a challenge in responding within that period of time. But what we do at the 20 working days, and we have not received all the information in which to respond back to the complainant, we would send them something called a holding letter. So that letter outlines that yes, we are still in the process of investigating, but because of foreseen circumstances, we would have a delay. So it's 2 working days for acknowledgement and 40 working days to respond. Yes. Sometimes if we have the opportunity to speak with the person, we would ask them, what would you like? Would you like us to send you a letter at the end of our investigations, or would you like to come in and speak with us at the end so that we can go through? Yes, so we would give them those options as well.
And speaking about the come in part, you can always come through the main entrance, make the right by the pharmacy, and it's just there on the left hand side. You'll see the label on the door, Clinical Risk Management Unit. We have a caller. Our first caller for today's edition, episode 3 of the Pulse Radio Show. Welcome, caller. Good morning. I got to get this good afternoon thing out of my head. Good morning. It's so hot outside, though. What's your question or comment, caller? Good morning.
Good morning. I am calling about, on behalf of a dear friend of mine who had a head scan, should I say, since the ending of March.
Right.
We've made several calls, to her doctor of the clinic. Doctor sent her there to get this test done. Today is June the 17th, and her doctor has not heard anything at all. I called the the help desk, and so far nothing's been done. No, she's been waiting for so long, like, I don't know if they're not in the materials or wherever to do this test or wherever, but I think that March, 3 months ago, is way too long for someone to wait on a test. Her doctor had called the department and was told that maybe there are lots of other people and whatnot. But I mean, in this day and age, why would someone to wait so long? I mean, and still suffering. You know, to me, this is not right. What is actually going on with in the lab department or whatever?
I understand.
And subsequent to that, she had another test on which I took her there. I think it was the April the 30th. And still the same thing. You know, what is going on?
Okay. Well, before I let Dr. Corbin Hart answer that, we want to thank you for your call, and we will have an explanation for you. Of course, we try to keep patient information confidential, and I'm glad that you didn't go into too much detail in terms of identifying the patient. But the response is something that we are very keen on getting done. We need to meet the patients where they are. You mentioned that the doctor would have called the clinic. What happens in this situation? Because she did mention help desk.
Yes.
And then she can send a complaint if she's not satisfied.
Correct.
To the Clinical Risk Management Unit.
Yes. So this is how Clinical Risk Management Unit and Patient Relations, how we work in tandem with each other. We are here for the patients. That's what both departments are for. I do have a few questions for you, caller, to be able to assist you better, because I'm wondering things that it's not clear to me from your description if the patient had the test and is waiting for the results or is waiting for the test. And the other question I would have for you is, does she have a clinic appointment? Because sometimes what happens is that the results are given to you at your next appointment. So a few questions I would like to have answered to be able to assist. So what I'm going to do is to ask you to call the help desk around after 1 this afternoon, and give all the details so that I can look into the case for you and try to get it solved. What I would ask Sandra to do is, Sandra, if this does go to a complaint, can you use this as a real life example to tell us what may happen here?
Okay. Well, if the patient relations team have not been able to hold you and your friend's hand as you go through to get the test results or have the test done, what we would have to do from clinical risk management is do a deeper investigation to find out the specific reasons why there was the delay, and then look to see where within the processes, as in the referral to having the test done, having the results sent back, then to look to see where we need to tweak within that system what are the things that or what we would call it root cause. What was the root cause? And actually look to see how best we can fix that or manage it so you don't have a recurrence. So that is where we would take it from.
The thing is there that she had both tests done on the 27th of March and the 30th of April. They were done. There's not an appointment to do anything. They were done. I actually took her to the QEH for the test.
Does she have an appointment to clinic, back to the clinic that would have sent her for the test? She would have gone back
there, and the doctor called the radiologist, and he's saying that there's lots of work to be done. There are other people.
Oh, I understand more fully now. So that sounds like the report has to be done. So tests do go through multiple points to be able to make sure that we get information accurately and that you're giving the doctors a more accurate description. So I definitely want to help you with this case.
3 months? Huh? 2 months? 3 months?
Yeah,
it is a long time. It is a long time.
But to you callers, some of these things do take time. But we really want to make sure that the person that you're calling on behalf of gets what they're supposed to get in terms of the results and the care, because every patient matters. That's the mantra of our Chief Executive Officer, Neil Clark. So I just want you to take this number, 536-4800. Remember, that's the help desk that you said you called.
I have that number. I called that number several times before.
Perfect. I like that, because that way you can get the feedback that you need. So you can call that around 1 o'clock this afternoon, and we will have your case, the case of the person that you're representing dealt with, so that you can understand what stage it is at, and so that patient can get the treatment that she needs.
And we can get a solution for you. So that's what help desk is for, part of the patient relations department. And I'll take a personal look at it for you to make sure that your friend is covered. So I want to thank you for raising that to us. This is part of the feedback that we appreciate, because we can't think of everything the patients will need on our own. We do think of some, but when we hear the real life experience from someone, that also helps us to improve as well. So I thank you for your call, caller.
Yeah, I call around 1. Thank you.
Thank you.
What I also wanted to add was the fact that it was not a situation where the caller was now expressing that there was an issue. She tried to access our services, and we would have had the opportunity to assist.
And,
so I hope
and that's what we want.
Mm-hmm. Yes.
As you mentioned, Mrs. Beckles-Hackett, Sandra, we welcome feedback. It is really one of those key things that we need to help enhance our services, so that the public in general can get a better service from the QEH. We have another caller. Welcome, caller, to the program. What's your question or comment?
Thank you very much, Mr. C. How are you doing this morning, sir?
I'm all right. I'm not.
Oh, glad to hear it. That's wonderful. Well, with great power comes great responsibility. You're responsible for this call. I have a couple of questions this morning, Mr. Seeley.
The couple. So let me just say to you, caller, a couple is 2.
I know. That is two. Right. So the first question has to do with the aspect of I would have, and let me thank the QEH for being able to help me out with when I had COVID, and I would have been a part of the new facility there at Harrison's Point. And when I went there, and I was given a particular medication for one of the symptoms of COVID, there was a significant risk to damage with another liver damage with another medication that I would have been taking for another symptom, for another disease. And then obviously when you come out and you are faced with the risk of taking it again, and when I say taking it, I mean contracting COVID again. But there are different circumstances this time, because if I contract it now, it will not be the same as when it was a real pandemic on the country. So I was trying to give you a particular situation to my experience in terms of when I dealt with the hospital and its care to me. And I would have, obviously, if there was a problem with the risk of the particular disease to public health, which it was at the time. COVID was a significant risk to public health at the time, and it took real resources of the hospital and so on, and they dealt with it very well. My question has to do with the aspect of why isn't there like a museum of some sort, or some sort of history of how the hospital dealt with that particular case in point, the COVID, where the country would be able now then to go forward, but do so by being able to access the hospital to pay for or some sort of facility that you can show, well, this is how we dealt with COVID, this is how you dealt with me in terms of giving me medication at that point in time. I don't know
if it could get so specific as to the medication, but
I'm going to give you a case in point, but I'm saying for the facility of like a museum or somewhere of the sort of the history of the hospital.
That is something that can be considered. Yes, it is definitely something that can be considered. You have another question?
My final question has to do with the aspect of now you have the clinical risk management and when you're talking about clinical care, you're talking about direct observation on the patient. In terms of the aspect of telemedicine and the newer technologies that would come where you're not actually directly observing the patient, you're using different technology techniques. You're doing it, you're trying to mitigate risk, yes, to the patient at all times, but you're not doing it under the clinical care as such. So I'm just wondering what kind of feedback would you want from the public in terms of the newer technologies, the telemedicine, the hospital becoming paperless and so on, being able to doctors being able to patients being able to give feedback in the new digital sphere with the digital record instead of the old notes.
Understood. Okay, you have said a mouthful, a lot of great feedback there and suggestions. I'm going to try to touch on each point. In terms of the hospital going paperless, that is definitely actively being worked on in the hospital digitization project. In terms of telemedicine, coming out of COVID, a lot of positive things. We do have some clinics that do implement a bit of telemedicine, and if I understand your point correctly, I think you were asking about clinical risk and telemedicine and not being able to fully observe patients. What I would say is that telemedicine is a specialty in medicine. It is a field that exists. It's out there. It's done internationally, and we do it to some degree here. So we know that the very, very ill patients, there's some conditions and scenarios where telemedicine would not be ideal, and the doctors would be able to delineate which conditions they can review the patient via telemedicine and which conditions they need to actually examine the patient. So when you're dealing with things like review of high blood pressure and diabetes, and the doctor wants to look at how your medication is impacting or improving your blood pressure readings or your blood sugar readings, then yes, that can be done via telemedicine. But of course, if a person has a broken foot or abdominal tummy pain, then the doctor will need to physically examine. So the doctors will know which are high risk, to which cases are high risk if you do telemedicine, and which cases are low risk. Of course, we do welcome the feedback, because as patients, as we come into this telemedicine realm in Barbados, patients can give us the feedback on how it works for them, and via clinical risk management unit, so that tweaks can be done as Sandra would have mentioned.
And of course, we will share all of these contacts for you so that you can know how you can connect with us at the Queen Elizabeth Hospital, just as you're doing here on the program, the Pulse Radio Show. Another caller on the line. Good afternoon. Good morning. Forgive me. Good morning, caller. What's your question or comment?
Good morning, sir.
Good morning.
I'm actually asking a question on a statement I think it was the second last caller made.
Yes.
Lady. And it's going straight to the eye clinic. Alright. We want to take the fear out of Bajans. Let me say about 65%. I just saying about 65% of Bajans have a eye problem. Right? And you make an appointment to see a eye doctor or the eye clinic at the hospital. Then you understand you gotta wait almost 2 to 3 years to get the problem solved. That is frightening, because persons now want to run to private doctors to get it done. They might not have no money, but they want it done because they don't want to go blind, because you know how Bajans go. Like, you're going to go to the hospital and wait 2 or 3 years and you're going to go blind. Persons don't want to go blind. How could the hospital help people to come out of that fear and get assistance, within more than a year, not wait 2 or 3 years?
Well, the first thing I'll do, caller, is direct you to our website, QEH Connect, www.qehconnect.com. We have a lot of content there. Among our content features, you will find one with our senior ophthalmologist, the head of department, the former head of department, Dr. Calendar, and 2 other specialists. Take a listen to that. They have gone through a list of things that are being done to address not only some of these longer lists that we are seeing in ophthalmology, but specialty care at every level. The waiting list in some cases can go up to a year, not 2 or 3. We've been hearing about a year. That is roughly the case. But a number of advancements are being made under the CAPEX, the Capital Expenditure Plan, to fast track some improvements in the Lions Eye Care Center and for the ophthalmology department, so they can better cater to our patients right across the board, especially in relation to ophthalmic care. So a lot of things are happening there. I know some people are currently on that waiting list, and we have our administrators, our teams getting back to them to tell them and update them what will happen as far as eye care is concerned. It's something that is being worked on. It's a work in progress, not only in the hospital, not only at the level of the hospital, but at the Ministry of Health as well, at the level of the Ministry of Health as well. So let me assure you, caller, these things are being looked into, no pun intended, and they are being addressed as we speak. But
thank you.
As I said, it's a work in progress.
Thank you, sir, and appreciate that answer, and continue with good work. Thank you.
Thank you very much for your call. And I'm figuring, Sandra, that even for things like that, people thinking that they're waiting a bit too long to have their treatment in terms of eye care, for that example, what can they do? Because they can make that complaint to the department, and then you investigate the processes, as you mentioned before.
Yes, they can. But apart from the person who is involved making the complaint, what we also have is the internal reporting process, where if the doctors from ophthalmology become concerned of the length of time that they are seeing that their patients have to wait, they alert us quite early as well, so that we can look to see where we can actually push and show the risks for that person waiting for that protracted period of time. So apart from getting the complaint, we sometimes would have gotten the alert early from our staff members saying, look, there's something going on here within this process, and we need to look at it to look to see how we need to improve our services.
I like that, the fact that we can focus on improving our services.
That is the aim.
That's the aim, that's the objective, and that's how we can focus on patient-centered care
and safety, which are phrases that we use every day. Sandra would know those are the things we focus on: patient-centered care and patient safety. We want the best for our patients.
Let's take a pause here, take a break. When we come back, we have Dr. Margaret O'Shea on the line as we have a highlight on transplants and what is being done at the QEH.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and much more. Conveniently located on Gemmitts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the Queen Elizabeth Hospital. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call now at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Welcome back to the Pulse Radio Show. I'm your host, Shane Seeley. Of course, I have my co-host with me, Dr. Rhea Corbin-Hart, and Sandra Beckles-Hackett is the manager of the CRMU, Clinical Risk Management Unit. And before we wrap up this program, we'll definitely give you all the ways that you can contact Sandra and her team to make your complaint, to let your concerns be heard, and also to share the many compliments that we get about the services at the Queen Elizabeth Hospital. One of those services offered at the QEH transplants, and Dr. Margaret O'Shea is one of the leads in transplant at the Queen Elizabeth Hospital. We welcome her to the program now. Dr. O'Shea, good to have you on.
Hey Shane, happy to be here.
So you have been pretty busy working on a number of things, but I know one of your passions is transplant, to save lives and to make the lives of your patients a whole lot easier. Talk about your focus and your vision for transplants at the QEH and a bit about what you're currently doing.
Well, Shane, thanks. Well, I think it's well known we do have a very large dialysis population, and this is increasing year on year. Due mostly in part to the increase in the non-communicable diseases. So the best approach or the best option for our patients with end-stage renal failure is kidney transplantation. Obviously, dialysis is there, and given the fact that patients who this time would benefit from a transplant need a live donor, we are not. We're not doing as much transplants as we would like, because in Barbados right now, the option for transplantation is only the live donor transplant. Mm-hmm. We do not have legislation for deceased donation at this time, but research is very clear on the benefits of renal transplantation for patients whose kidneys are no longer working. They live a better quality of life, they live longer, and you're not spending all that time on dialysis machines, and certainly you can go on then to be productive, have babies, both the donor and recipient. And we, internationally all over the world, transplantation is the best form of treatment for patients with renal failure.
And the good thing,
no longer working.
Indeed, and the good thing is the legislation in the works. The Minister of Health is moving in that direction to ensure that we can take steps to have more organs available for transplant generally. But looking at the population, I'm talking about the patient population. Approximately 350 patients currently on dialysis. How big of a deal is it to have more kidney transplants to help reduce the number of patients on dialysis? Talk a bit about the benefits.
Yes, well, the benefits, patients who are on dialysis, they have a very strict diet. They also suffer long-term with heart disease, which can lead to earlier death. And they also have issues sometimes having the catheter in the neck, they're in the heart, which puts them at risk for infection. That's for the hemodialysis. The other option is the peritoneal dialysis, where you have the tube inside the abdomen, helping to cleanse the blood. So these are two options, and I'm not saying some patients, they're managing, but we find that when the patients who get the transplant, they are certainly able to, go back to their work more readily, and you just then taking medications so you don't, reject the kidney, and it is better quality of life, and also better quantity of life, and certainly more cost effective for the hospital. Patients, the dialysis is expensive, but when you get to the point of just, needing the immunosuppressive drug, it's certainly more cost effective and less cost to the hospital.
I know
so we see win-wins in every direction.
And win-wins, that's what we want. I know family members will have many questions, and you have a question and answer forum coming up later this week. Talk a bit about matching patients for transplant.
Right, so you don't necessarily need to be a blood relative, you can be a friend, but we do prefer the blood type match, and then we can drill down more into special types of matching. So, we know that O is a universal donor, so somebody who's O positive can give a kidney to somebody who is O positive as O as well, or B, or A. So we just do the blood type match first, and then there's a more detailed type of match that we do later on, once we make sure the patient is fit for surgery. That's the other thing. Our donors, we screen them very heavily because we don't want anything to happen to the donors. So they get all of the tests done to make sure they're very healthy and fit for surgery, and they're not at any risk of ever needing to be on dialysis themselves. Actually, a lot of research shows that people who donate kidneys live longer than the average person because we keep an eye on them ourselves, make sure that they're sticking to their diet and they're exercising, and you only need one kidney to live a happy and healthy and a long life, one functioning kidney. So you have two. So I think if you have a relative who is in need or a friend, we do all the typing to make sure everything is safe. So we just would encourage people to come forward on behalf of their family or close friends.
And talk about the success rate.
Right now, we partner with a group out of the UK called Transplant Links Charity. So our patients, we have a multidisciplinary meeting where we discuss all the patients coming for surgery, and we have close to a 90% success rate at this time. Nothing is perfect, and some patients, well, so far all of our grafts have worked, but we do have patients, because they have that underlying problem, do succumb to some other issues, one or two, because of the diabetes and hypertension that they already have. So, there is that concern sometimes, but we vet them very heavily, but we do have a very good success rate with our patients. And because, we know we have a small program, so we're careful, and therefore we partner with the team that is doing a lot more than us to make sure that what we're doing is the correct process, just to give us that kind of observation and to make sure we're doing everything correctly. And
Transplant Links Charity, a partner
yes.
working with the Queen Elizabeth Hospital. We thank them for doing that for a number of years. They'll be here on the ground again, and we look forward to their time here. They'll be spending some time on CBC TV 8 as well, as we really talk about the developments that we are trying to have here for our transplant program and really fulfilling your vision, Dr. Margaret O'Shea, in terms of getting more people having a match and really leading to longer and healthier lives for our dialysis patients. Thank you for coming on the program, Dr. O'Shea. Of course, we know you'll be back sometime to talk a bit more about the developments and, of course, about the successes in the program.
Yes, thank you. And as you pointed out, we're having a Q&A Friday at 1 p.m. at the Queen Elizabeth Hospital in the auditorium. If you have renal disease, you have any concerns in transplant, bring your family along so they can hear directly from the experts about how to go about it and what we offer. That's Friday, 21st at 1 p.m. Transplant Links Charity team will be here.
Sweet. And of course, we will share that information on our social media pages so you can check it out and see how you can be a part of our discussion. We have a pretty big auditorium. We can welcome a number of families who would be concerned about their family state in terms of their dialysis. But more importantly, how can they move from that stage, possibly getting a transplant, and then leading to longer and healthier lives for more of this 350 patients that are currently on dialysis here in Barbados.
Definitely a big feat that the government of Barbados is accomplishing year in and year out.
And a lot of money. A lot of money being spent to help.
To make sure they get their dialysis. You can't break dialysis. You can't, we can't say, we're gonna not do this week. We're not gonna do next week. We can't do that. Dialysis patients need their dialysis some 2-3 times per week, and that's what Dr. O'Shea was speaking about in terms of quality of life, because you can imagine if you want to take a trip overseas, you have to make sure you're going to a country where dialysis will be readily available to you. You have to plan out all of that beforehand, contact doctors overseas, etc. But in the event that you are able to get a transplant and it is successful, then that's just one example where it's definitely easier.
And the numbers are encouraging, 90% success rate, so we definitely have a platform to move off of. Of course, we're talking about the clinical risk management unit here on the Pulse radio show with Sandra Beckles-Hackett, the manager of the department, so we'll get back to that discussion. Of course, transplant and the transplant program, that's just a highlight of what is being done at the QEH as we continue to enhance our services. Let's go back to the phone lines and welcome another caller. Good afternoon, caller. Welcome to the program. Good not afternoon.
No, good morning.
Yeah.
Good morning.
So caller, forgive me. I do not know.
Shane,
I don't know why I'm rushing the day.
You asked for forgiveness about 3 times, Shane. 3 times.
You know what? I'm glad that myself and Sandra and you, Rhea, had that prayer before we started the program, because I know my prayers will be answered. Good morning, caller. Welcome to the Pulse Radio Show.
Listen, I have a friend got cataract, and I got to get them cut. And this is a year and a half. The Kennedy hospital keep putting them off, putting them back, putting them back.
Mm-hmm.
And the person is 66 years old.
Okay, but there could be a number of reasons for that. Sometimes when a patient goes for a cataract, we hear this story so many times, Dr. Carbon-Hart. They're not fit for surgery. Their pressure may be too high. Something may be wrong, and then we have to reschedule them.
I think once or twice to say that.
Yes.
But I mean, a year and a half, put them back. Then they're ready to do it. The person will get blind.
Yeah, but the patient needs to take some responsibility for their health as well, to make sure that they're in appropriate condition to access that treatment.
Yes.
Dr. Carbon-Hart, you want to say a bit more on that?
Yes, I was just going to add that because we have a long waiting list, we do have an aging society, we do have a society with a lot of NCDs, so we do have a lot of persons who require ophthalmology surgery. What happens is that if a person misses a surgery for whatever reason, their rescheduled date will be quite far, because the hospital is trying to fit in everybody, so they actually do the planning out of the surgery list for months to come.
Right.
And this is what we speak about with the feedback, because as you mentioned, it is now part of CapEx to try to increase the
capacity.
The capacity, exactly, that's the word. So that is how the feedback helps us. And to caller, that is a little bit of an explanation of how someone can be put back for a prolonged period of time.
And let me just add to that, caller.
Put them back all the time.
Caller, what you could do on behalf of that patient too, you have 2 other options. You can call the Patient Advice and Liaison Service, PALS or Help Desk, at 536-4800. And let the 536-4800.
4800.
Yes, to have that, just as you explained to me, tell us what's the situation, so that we can log the scenario and look into it. And then if you want to take it even further, you can make it a complaint and send it over to Sandra Beckles-Hackett in the Clinical Risk Management Unit. Yes, Sandra Beckles-Hackett.
She may be family to me. I'm a Hackett too.
You're a Hackett too.
And
the family from St. Joseph.
You from St. Joseph too?
She's not in.
And she's not in. She is not in. So
that's my family then.
So this is what you can do. You can visit Sandra in the Clinical Risk Management Unit when you come through the main entrance and make the right. The door is right there on the left hand side, basically next to the pharmacy. And you can go and ask Sandra first if she's your family, and then seek assistance for that person that needs that eye care. That you said that she's been waiting on for a year and a half, and you mentioned that she did have a couple situations where she was not fit for surgery. But come in.
If she didn't have the money, she would go on and pay for it.
That's an option as well. But we want you to use some other options here.
It didn't work over 2 years now.
But you can make some calls for your friend. If you let your friend, make some calls for your friend, so that we can make sure that she's dealt with.
Yeah.
So you can call Sandra. You can come and look for Sandra?
Yes.
Oh, sweet. So come and look for Sandra. Find out if she's family to you first, and see if your family can help you.
I'm looking for Shane Seeley.
Oh, you near call me rote, I know. But listen, thank you, caller.
Shane Seeley.
Yes, please.
Thank you. Have a good day.
And you have a wonderful day as well. 11:48 is our time.
We have a lot of really good friends today.
Yeah, and family members.
Looking out for their loved ones. Yes.
And family members. So Sandra, you got somebody to look up for when they come into. So like a situation like that.
Looking for.
Right, you'll be looking for her, and whether she's family or not, she's going to be dealt with. So she doesn't have to worry.
Yep.
But yes, you'll be looking out for her. And this is what we talk about with feedback, because there's so many avenues. The internal customers, which is the staff of the hospital, they can give their feedback of how long their lists are, as well as the external customers, which would be the patients and their relatives. They can give their feedback of what is happening to them as a result of the treatment that they need.
What I like to Rhea, is that I find that a lot of members in the community They don't necessarily have to be next of kin or family, but they're calling on behalf of a friend, a loved one, hearing a story and seeking help for them. This is what we call being our brother's keeper. This is something that we've seen fallen off in a big way in our society, that we are trying again to promote. So if we can do that through this Pulse radio show, through this little hour that we have here on Q100.7 FM, we're definitely happy that we could be of assistance.
I think, Shane, you just came up with another topic that we have to talk about.
What's that?
This next of kin topic. That's a really big one, because next of kin is a whole legal word. It has a lot of legal implications. However, in our society, the culture is, I concerned about Sandra, so I calling about Sandra. I don't care if Sandra's husband called. Sandra is my friend from school, and I want to make sure Sandra is good. And we welcome that to some extent. We just want to streamline it. So I think we can add that topic to our list of topics.
For sure. Definitely. Speaking about a list of topics, I know, Sandra, you have a number of things that you want to cover in terms of how you can help patients better communicate with you. Anything else that really is top of mind for you in terms of making that connection easier for our patients?
Well, we've mentioned that they can walk in at any point in time. We have an open door policy. They can call the 436-6450 extension 5248, 5249, 5234 to name a few of the numbers I would have called. And if they're computer savvy, they can go on QEH Connect, or they can email the crmu@qeh.gov.bb. But what I wanted to get into before we run out of time is letting persons know what is happening on the back. The internal wheels that turn when we are made aware of various issues, and even to find out what other issues that can be picked up within the hospital. What we have started when we receive the complaints, or if another member of staff have alerted us through the reporting process within the hospital, we have started our risk management meetings, where we meet with as high up as the head of the department. So it could be the head of department of pediatric, accident and emergency, surgery, whichever department. And we go through the incidents and the complaints that come through related to their area, and look to see these are the things that are happening. And the discussion has been so good so far. And what we have actually been putting in place are action plans. So each time we meet, we look for updates on the actual action. So it's no longer saying, oh, we're going to do this, we're going to look at this. But we are keeping in touch as to what are the actions and if they're actually implementing the actions. Because if we see a repeat of the incident, or somebody coming again with a complaint related to the same issue, we can actually say, refer back that these are the actions, where are we with these actions, and so on. So those are some of the key things. We're also looking at doing risk assessments. We used to do them before, but there was a lag, because as time goes on and you get more activity going on, risk assessments where we are looking at the department even before they report an incident to see what are the using performer to look to see where are issues within the actual system or within the department that we can look to start putting actions in place even right away before an incident gets to a patient, before something happens to a patient, before somebody has the reason to complain. So those kinds of things are the things happening in the background as we receive, or sometimes not even receive, but nosy to look to see what is happening. The good nosy, so that we can look to see what is happening.
You're making it your business to make sure that patient safety is covered as best as possible.
Yes.
Sandra, it seems that your process is extremely streamlined. It seems that you have, to use the phrase, all your ducks in a row. And this is reminding me of the fact that we follow strict guidelines and strict international standards and try to adhere to these standards as best as possible. And I believe that your work and the work of your team, your small team, is part of why we have been able to attain gold in accreditation. So I do want to thank you and your team and congratulate your team on paying attention to these patient safety matters every day as we go about our work at the hospital.
Before we go to the phone lines, we have a question via WhatsApp. It goes, good morning. If a doctor instructs a patient to get their notes from records, the records department, and the patient provides the information and pays, upon collection of the notes, maybe they might not be present. I'm trying to interpret through the wording of this message. So the real question is, why is the patient not refunded the monies, or something better worked out to resolve the issue rather than just given a polite dismissal? So I will say to this question, and I know that you will add to this as well, Dr. Corbin Hart. When you have issues like these, this is an issue that you can also take to the clinical risk management unit. So if you go to medical records and you're not satisfied with what happened there, you can take a short stroll down to Sandra's department, which is right down the corridor. You can ask any of our friendly staff, security, and they will direct you. And you can make a complaint of this nature and have your matter resolved. It might be quicker than you think. I know Sandra said 48 hours for the initial response, but something like this is as easy as a simple conversation in some cases.
Yes.
So some of these can be resolved in quick order.
And definitely coming in or even calling, but coming in or calling definitely helps, because I can immediately say that I and I'm sure Sandra, we have questions about this. To be able to pinpoint certain things, because something here we need a little bit more information to be able to pinpoint how we can help the patient. So this definitely would help if it's a conversation, so that we can get all the information to assist.
And we got a few more minutes to give you those numbers. Let's go back to the phone line very quickly for the final caller of the morning. And I said morning. Good morning, caller.
Our prayers have been answered.
Welcome to the Pulse Radio Show with the Queen Elizabeth Hospital on Q100.7 FM. What's your question or comment, caller?
How are you all today?
We're good.
We're good, thank you.
Very good.
I'm calling about the cancellation when a person is admitted to the ward and they get there and notify that they're somehow, somewhere, a nurse report to them that due to circumstances your surgery has been canceled. That time you got your little luggage back, when you're going way up on the plane.
Georgie bundle.
You got your Georgie bundle, you're ready to go into the ward. And when it's canceled, how long does it take to they call you back then? Because that time the person could be getting worse.
Definitely a concern that is quite understandable. There's no direct answer to this question, because it depends on so many different factors. It depends on the reason for the cancellation. Was it that a case before took longer than was expected because the doctors found something that wasn't expected on the surgery? Was it a case of the patient's condition at that time not being ideal for surgery? It could be so many things. It depends on the current list of the team, the specialty. So many factors come into play. That's a hard question, but I'll let Sandra expand on it for you.
Yes, what I wanted to also ask you, the question that you asked was, how long would it take for that person to have to come back for the surgery? What I can tell you is more often than not, when the persons have come with concerns like yours, what we have found is that the doctors have carefully assessed the seriousness of that person that they have to cancel, and they would then bring them back onto the list based on the seriousness of that person's condition. So it is not that it is a number and then the person then comes back at a later date. They are triage or for use of a better word, they looked at as to what the condition is that the person would have, and then what happens is then they are fit back onto the list to match the seriousness of their condition. So if that is a concern of yours, that is one of the things that we would usually pick up or find out when we communicate with the teams when we have concerns.
I was definitely admit to B6. That was on the day before the bank holiday last month. And me and the gentleman, we were there sitting down. So we couldn't go in yet because they told us that the morning staff have not finished their work yet. And then a nurse called us in, so I was like, whoa, I'm going in now to hear the procedures now. You know, that kind of fussy way, because I don't want to be down, I don't want pressure drop, nothing, so. Then the lady I see the lady with this piece of paper asking us for our numbers.
Yeah, for that
I
call.
I told her numbers. I get admit to all the numbers when the admission paper there.
But there's a reason why they do that, though, because they want to make sure that you are who you say you are.
Right.
so that's for identification purposes.
Numbers can change as well.
And that too. Caller, our time is very slim, so we got to run, but we want to thank you for your call, and it helped us to address a number of issues that we have at the QH that we will address going forward. And also, when you have these situations, I gave the numbers pretty much right through the program that you can call 536-4800, and you can go on our website and see all the numbers for the Clinical Risk Management Unit, so that you can find out how to have your concerns heard there and your investigations done, and find out when you are going to get feedback from Sandra and her team. But again, thank you for her call. I want to do a quick notice before we go off today. There's an open donation to the St. Ambrose Primary School coming through our 60th anniversary donation drive being done by the nursing department. So we're asking people to come in later this week around Wednesday. We'll have a like a barrel set up near the entrance where you can bring your non-perishables, some school items, new clothes as well. Please, we're appealing for new clothes as well to help those students at the St. Ambrose Primary School. Remember, recently they were affected by fire. We're doing a donation tomorrow, and we want to do another one next week. So for those of you coming through the hospital, you can walk with those school supplies, toiletries, and non-perishables food items to help those at St. Ambrose Primary. We have adopted the school, and we will help them.
We're our brother's keeper.
Definitely. So Rhea, next week by popular demand, we have to go back to the accident and emergency department. So Dr. Cruikshank will be back to spend some time with us and answer your burning questions. We're dealing with all the hot topics.
Yes.
You're straight off the bat. Yes. So as we open the batting here on the Pulse Radio Show, we can take the pace quick like fire.
You're making us part of World Cup.
Yeah, of course. Rally around the West Indies all the time. But listen, thank you for spending your time with us here on the Pulse Radio Show. We will see you next week for episode 4. A big thanks to Sandra and the Clinical Risk Management Unit. Me and my sidekick Rhea. We will see you next week. Bye until then.
You've been listening to Pulse, the QEH radio show, brought to you with the kind compliments of MedSafe Medical Supplies Limited. For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and much more. Conveniently located on Gemmitts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the Queen Elizabeth Hospital. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call now at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.